In this video, we're going to talk about pain management strategies as they relate to emergent pain management or pain management in the pre-hospital setting. When we look at management of pain, one of the primary considerations has to be that pain is undertreated. To give you some perspective on what this means, only about 60% of patients presenting in pain, whether in the pre-hospital or emergency setting, are going to be receiving any type of pain management. When we look at efficacy in pain management, we know that moderate to severe pain is treated best with opioids, and even fewer of these patients receive opioids. So of those 60%, a small fraction of them are actually receiving opioids despite presenting in moderate to severe pain. And even fewer of these patients are presenting or being provided comorbid pain management with things like NSAIDs and opioids. So multimodal pain management is even more rare for these patients. To give you an appreciation for impact, about 74% of these patients will still leave the hospital in pain. So despite pain being the primary presenting problem for these patients, typically what's happening is less than 60% or around 60% are receiving any pain management, fewer receiving opioids, even fewer receiving comorbid pain management strategies like pairing an NSAID with an opioid. And as a result, about 74% of those patients are still leaving the hospital in pain. So we haven't had a resolution of the complaint that they have come in with. Now, the evidence tells us that there are a number of factors involved in what leads to disproportional or undertreated pain for patients presenting in acute pain. And these include bias, inappropriate pain criteria, patient reporting of pain, and then overstated risk. When we talk about things like bias, often there are unconscious or conscious biases that play a role in leading to less pain management. For example, the evidence tells us that people of color typically receive less pain management than Caucasian patients, and this is going to be regardless of who is treating their pain. The problem with a bias like this is simply recognizing that a bias does exist typically doesn't prevent a person from continuing to employ an unconscious bias. So extensive training and mechanisms to overcome this bias have to be put in place in order to recognize that it exists and then overcome it in the treatment of pain. Some other aspects that are going to play a role here are inappropriate pain criteria. So using things like an increase in heart rate or physiological criteria to determine patient pain when pain is truly perceived by the patient and we may not see increases in things like vital signs. An example is that an increased heart rate is not significantly associated with pain, or it's not proportionally related to the patient's degree of pain. So using that as a criteria for determining whether the patient is or is not in pain is inappropriate. In addition, things like the appearance of pain in the patient is dependent on a lot of different factors, contextual factors, patient factors, cultural factors. So using pain perception based on patient appearance is not a good indicator of whether the patient is or is not in pain. Patient reporting typically will result in less pain management. Often patients will believe that they should feel less pain following some sort of management, or they'll try to meet the expectations of the healthcare provider. This leads to a large reduction in pain reporting. After the administration of pain management medications, often patients will report lower levels of pain despite not feeling any change in their pain, or will state that they indicated to the healthcare professional that their pain was lower than it actually was, based on biases or what they felt the practitioner was looking for. Finally, overstated risks typically play a role in terms of withholding opioids for patients. So again, typically when patients are experiencing moderate to severe pain, opioids are the best strategy for managing that pain. And the challenge is that most practitioners will overstate the risks, things like apnea, addiction, hypotension, and which will either position the patient away from accepting that line of treatment, or it will lead to the healthcare professional themselves deciding not to treat the patient with an opioid. Again, typically these medications and the doses that we're providing or we're following best practice guidelines are designed to avoid negative consequences, and when compared to other medications, typically do have very limited and insignificant consequences for the patient when being given in those best practice settings. So if we think about what that means from a care perspective, is typically we should be taking patients' perceptions of pain at face value. We should be creating an environment where patients feel comfortable outlining and explaining the severity or degree of pain that they're experiencing. And we again should be making sure that we're not setting unrealistic expectations to the patient of what we expect in terms of their response to pain. So again, our bias or use of inappropriate pain criteria can actually lead to underreporting of pain by those patients. And again, if we go back to what the data or the evidence tells us, is that 74% of patients are still leaving the hospital in pain. When we look at the pre-hospital setting, there are few consequences to not treating pain. So, for example, a short-term outcome in the pre-hospital setting is that not providing pre-hospital analgesia will typically lead to reduced chances that that patient receives in-hospital analgesia. So again, making a decision in the pre-hospital environment can impact the care the patient receives in the in-hospital environment. The evidence also tells us that there are long-term outcomes associated with not treating acute pain in the emergency or pre-hospital environment. These consequences include a decrease in quality of life. So the metrics that are used in order to identify this are things like chronic pain. So how does acute pain lead into chronic pain? And what they find is that 4 weeks after discharge of presentation at either the emergency department or the pre-hospital department with pain, if the patient's pain was not managed at that time, they will still present in pain 4 weeks later. So we're moving into the potential for a chronic pain issue. What they also find is that those patients have a reduction in scales associated with physical and social functioning. So patients whose pain was not managed in the acute setting, often 4 weeks post-discharge, are still presenting with lower levels of physical functioning and social functioning than those patients whose pain was adequately treated in hospital or in the pre-hospital setting. Finally, when we look at quality of life, we also look at things like sleep quality, which is typically still impaired 4 weeks following discharge if the patient's pain wasn't managed. So when we look at the long-term consequences for the healthcare system, we could be taking or positioning a patient who's presenting in acute pain, who's not receiving management, and then leading to more long-term outcomes as that pain is not managed. In terms of other long-term outcomes, what we typically see is higher prolonged pain scores and a decrease in global physical abilities. So these patients are typically presenting in the long term with higher prolonged pain scales or pain scores, and are often presenting with lower global physical abilities the longer that pain remains unmanaged. And again, this can start with the decrease in the management of that acute pain or that initial acute pain episode. And finally, it increases the risk for development of chronic pain. So when we look at longitudinal studies of these patients who, again, are presenting in acute pain, so we're controlling for patients who have chronic pain, someone presenting in acute pain, unmanaged in the pre-hospital or emergency department, it does increase their risk for the development of chronic pain as we move further. So again, when we're looking at strategies to combat this, one, we should be taking pain at face value, trying to avoid bias, and ensuring that we have adequate reporting of pain so that people are leaving or being discharged without pain. And often one of the best strategies for this is going to be multimodal management of pain. So typically pairing something like an NSAID with a narcotic. There is evidence to suggest that when someone has an NSAID and a narcotic, NSAID will reduce the amount of narcotics required moving forward. So less opioid required in order to manage that pain effectively, lower doses of opioid needed to manage that pain effectively, and better long-term outcome. This could mean, if available, pairing other medications for pain management with the opioid in order to get the relief that we're looking for these patients.